come a long way since we were cavemen. So there are billions of species on this earth. But what made us special? What is the secret of our progress? Of all the species, why is it that only our species was able to have such an evolution in scientific progress? Was it our DNA? Was it our opposing thumbs which enabled us to use instruments? Or was it our brain, oversized brain, which made a lot of conceptual thinking possible? There are many theories, but one of the pertinent theories that has to be thought of is that we have the ability to learn from the past. We have the ability to teach. We have the ability to learn. Knowledge that was learned over the generations have been passed down. Hundreds of years, thousands of years, the knowledge that we have gained, our species has gained, has been transmitted. And it is based on this knowledge that we are able to progress further. If we didn't have the knowledge that of our forefathers, we would not be able to progress in the way that we do today. So let's just keep that in mind and let us come to what medicine is. So medical knowledge that we have today, it did not appear from nowhere. It has been built on the lives of countless people, without whose ideas, inspirations, mistakes, and sacrifices, the world or the medical knowledge that we have and that we know today cannot really exist. So let's come to our topic, management of chronic heart failure. It's a continued challenge and has a very exciting future. So what is heart failure? Heart failure is defined as a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. So there are a few terms here that we have to take into special consideration. A complex clinical syndrome is a collection of signs and symptoms. This collection of signs and symptoms are brought on by some structural or functional change that impairs ventricular filling or ejection. The ventricle, it fills with blood and it ejects blood. So there's some impairment to either of these two functions, and that is what is manifested as heart failure. So what are the important symptoms that patients experience? So symptoms are the most important fundamental point to think about, because from the patient's point of view, it is the symptoms that is most important. It is the symptoms that are going to bring the patient to for medical care as well. So when you look at heart failure, we have shortness of breath, swelling of ankles, tiredness, fatigue, and malaise. These are the most important symptoms that we will find with heart failure. Shortness of breath can manifest from shortness of breath on severe exertion up to shortness of breath at rest. The patient may be unable to lie down, which we call as orthopnea. Patient may be developing intermediate shortness of breath after he goes to sleep, which we call as paroxysmal nocturnal dyspnea. So there are many manifestations of breathing. Then we have swelling of the ankles, which is a manifestation of sodium and water retention. And then we have tiredness, fatigue, and malaise, which is a manifestation of impaired cardiac output or impaired tissue perfusion for the cells of the body, resulting in all these symptoms. So heart failure itself is the end stage of all the diseases of the heart. So heart failure itself isn't really a disease. It is a manifestation of all the other diseases. So there are a whole myriad of diseases that affect the heart. But the common ones are coronary artery disease, valvular heart disease, hypertensive heart disease. So the top three, those are the three ones that are most commonly going to cause heart failure. Then we have our congenital heart diseases and cardiomyopathies. So all of these, the end stage is going to be heart failure. If you look at the prevalence of heart failure, it is quite prevalent. If you take 1,000 people in the population, 3 to 20 people are going to have heart failure. And as the population ages, when it's over 65, then for every 1,000, there is 10 people who have heart failure. That is one in 10 people have heart failure over the age of 65. And the incidence of heart failure is also around 1 to 5%. And after the age of
Dr. Rajeevan, we can't hear you.
Rajeevan, there's interruption. It's some technical problem. We can't hear you. Dr. Rajeevan, there's a technical problem. We couldn't hear you. Now we can. Now we can.
Okay. So today, if you take cardiology per se, there is a whole myriad of treatment modalities, intervention modalities, medications, monitoring facilities, diagnostic facilities, a whole myriad of things which is really unimaginable. But how did we come here? How did we get to this point of where we are today? What was the path that medical science took to reach the point that we are today? So let's go back 3,500 years. So this is a big mummy of a nobleman called Nebri. He was a person who looked after horses actually. And he's the oldest known case of heart failure. He lived 3,500 years before Christ. And his mummy was preserved. His parts, actually the parts of his body were preserved. And histology of his lungs described pulmonary edema. So his cause of death had been pulmonary edema due to chronic heart failure. There were changes of chronic heart failure in his lungs. So he had died at around the age of 40 to 60 years. So heart failure is nothing new. It has been known from all the ancient medical systems. So there are descriptions of heart failure in the Egyptian medical systems, Indian, Greek, Chinese. All of them described heart failure in varied ways. So it's not a new thing. The Roman period, foxglove, which had a digoxin-like chemical, this was used during from the Roman period up till very recently. It was used for heart failure. Fluid retention that we find in heart failure was also known throughout the centuries. This was managed by things like bloodletting. So bloodletting was a way of removing this excessive fluid. And also in the bottom picture, you can see leeches were also used sometimes to remove blood or remove fluid from the body in order to bring down the fluid retention, which was causing problems. A medieval scholar, Avicenna, he was known as an authority on heart diseases. He actually wrote a book on cardiac diseases in where he had described the various therapies that were available at the time for breathing, palpitation, and syncope. So all the features of heart failure are also described in this gentleman's book. But pathophysiological understanding of heart failure, as we know it today, it started with the discovery, or with the description actually, of the circulatory system by Sir William Harvey. So following this description of the circulatory system, where we understood that the heart was a pump and it carried blood out of the heart, and there were tubes that brought blood back to the heart. So when this understanding developed, after that, many discoveries followed. So heart failure due to valve diseases, tamponade, that there was an entity of acute heart failure, chronic heart failure. The scientific method was used, and many scientific articles came up where renowned scientists were able to, or medical scientists were able to piece in all the knowledge that was built up over the centuries into William Harvey's picture. So this gentleman, William Withering, he wrote an account on foxglove, that was digoxin, or the digitalis like effects. It was written in 1785. So this was the first medical literature in modern medicine that we know of outlining the therapeutics of heart failure. Heart failure was very, very important, so much so that this gentleman, Sir Thomas Lewis, it's a famous saying that the very essence of cardiovascular practice is the early detection of heart failure. So cardiovascular practice was basically managing heart failure. That was it at the time. Now, for some time, mercurial compounds, compounds with mercury, had been extensively used to manage syphilis. So at the time, they found that these mercurial compounds, they were able to produce a diuresis. So because we already had an idea that fluid retention was important for management of heart failure or management of fluid retention, so these compounds were used as a way of removing bloods as diuretics. So these were the first diuretics to be used. However, in 1958, when the thiazide diuretics came up, so this was a safe alternative because the mercurial compounds, they were causing a lot of side effects and toxicity. So until the 1980s, this back-forward flow theory was what how heart failure was described. That is, heart failure was described based on preload, cardiac contractility, and afterload. And heart failure was managed symptomatically. The main managements used to be bed rest, inactivity, and fluid restriction. Medications-wise, digitalis and diuretics were prescribed. So this was all the management until the 1980s. So then in 1986, in 1986, an important trial, hydrazine and isosobide dinitrate, was used in the vasodilator heart failure trial. Hydrazine was a smooth muscle relaxant, so it reduced afterload. Isosobide dinitrate was a venodilator, so it reduced preload. And this combination showed for the first time that some type of medication can reduce the mortality in heart failure. So there was a 34% reduction of mortality for a 2-year follow-up. Now, okay. Then again in the 1980s, heart failure as a neuroendocrine disease, the understanding started to develop. So interestingly, it was some studies which were conducted in India, which were the first studies which proved that there was a neuroendocrine manifestation to heart failure. So this demonstrated that the neuroendocrine system is activated in untreated heart failure, and also that the same response, it is the same response that is seen with when a patient exercises or has an acute myocardial infarction. So many of our management aspects thereafter were based on this understanding. So this understanding basically, so this is our understanding of our current understanding of what heart failure with reduced ejection fraction is. So there is activation of this renin-angiotensin aldosterone system. So there is reduced cardiac output, reduced cardiac output causes reduced renal perfusion that will stimulate the juxtaglomerular apparatus to secrete renin, and thereafter this system is works and we get angiotensin coming up. So this leads to vasoconstriction, sodium water retention, as well as interstitial fibrosis in the heart. At the same time, when the cardiac output drops, the body thinks that there is not enough intravascular volume, there is not enough, the blood pressure drops. So therefore, the sympathetic nervous system is activated. This leads to vasoconstriction, increased heart rate, and that also causes myocardial toxicity. Then we have another system, that is the natriuretic peptide system. You all have heard about ANP, BNP, and so these natriuretic peptides, they get activated, and this activation is actually a good thing. It causes vasodilatation, diuresis, and also inhibits this interstitial fibrosis. So these are the changes or neuroendocrine changes that occur with heart failure. So then, based on this neuroendocrine understanding, a number of studies came up. So one was this consensus study, where for the first time ACE inhibitor showed that there was an unequivocal survival benefit. That means there was more than 40% risk reduction in the enalapril group compared to the placebo group. Also, another trial, studies of left ventricular dysfunction, this also showed similar results. So thereafter, the CALM trial, this showed that angiotensin receptor blocker is also effective. It actually showed that the andesartan had similar benefits to enalapril. So it's based on these studies. And there was another study as well, valsartan, which was looked at. So valsartan versus ACE inhibitor was also looked at, and that also showed similar benefits of ARBs as an ACE inhibitor. Based on these guidelines, that we currently recommend that patients with heart failure should be treated with an ACE inhibitor, and if they cannot tolerate ACE inhibitors, then they should be on an angiotensin receptor blocker. So what are the medications that are recommended? So we have, these are the recommendations, and the important thing is to go for the target dose. There is no point of just giving small doses of captopril or enalapril or partial doses, because all of the studies have shown that as the dose increases, it's a dose responsive benefit. As the dosage increases, the benefits increase. So therefore, it's important that we should always, when we manage patients with heart failure, we should try our best to reach the optimal doses, that is the maximum tolerated dose, or if we can reach the target dose, that is fine. Aldosterone itself, it causes a lot of problems. It increases sodium water retention, it has it causes vascular endothelial dysfunction, it increases the cardiovascular fibrosis. So it's obvious that if there is something that inhibits aldosterone, that also will be efficient in managing heart failure. So it's based on this idea, this theory, that a real study was conducted which showed unequivocally that spironolactone, when added on top of ACE inhibitors or ARBs, had a better effect in managing these patients. Then the emphasis trial, this looked at eprenone, which is another mineralocorticoid receptor antagonist. And this trial was stopped early because it showed definitive benefits. So there was a 37% reduction of deaths and hospitalization. So it was again based on these studies that mineralocorticoid receptor antagonists are now recommended in addition to ACE inhibitors and beta blockers. So the recommendations are to give spironolactone or epinephrine for patients with an NYHA class of 2 to 4 with and a left ventricular ejection fraction of less than 35. Or if the patients have a LVEF of less than 40, if they are developing heart failure symptoms, or if they have any history of diabetes, then also mineralocorticoid receptor antagonists are considered. Now, beta blockers are also very important because they cause direct myocardial toxicity. They also increase the vasoconstriction, putting more workload on the heart. They increase the heart load. So the myocardial, it becomes a vicious cycle. So beta blockers studies were done to see on what was the effect of beta blockers in heart failure, and it showed that beta blockers improve mortality and morbidity. It decreases cardiac remodeling and also reduces hospital admissions. So this was the first trial which was done on with using metoprolol. So the results showed that metoprolol caused an significantly lowered the all-cause mortality. And actually, this study was halted early because the results were so definite. So these were the results that we were able to see with metoprolol. Then a Copernicus study was done using carvedilol. Copernicus study also showed that there was a definite benefit when we used carvedilol, and it reduced the all-cause mortality significantly, and also reduced hospital admissions to a large extent. So again, yes, there was another trial, the CBIS-2 trial, which looked at bisoprolol, which again showed that there was a definite benefit. So again, based on these studies, beta blockers were recommended as a management for heart failure. So that's why it's actually these three medications, bisoprolol, metoprolol, and carvedilol, that are recommended for heart failure. It is not any beta blocker. Nebivolol also, there is a study of elderly patients where nebivolol was shown to be effective. However, still nebivolol has not been recommended as a beta blocker to be used in heart failure. So the medications, again, we start at a low dose. So if we take bisoprolol, we start at 1.25 milligrams daily. And depending on the patient's how the patient tolerates, we go for our maximum target dose. We aim for a resting heart rate of 60 beats per minute. So the third arm of our pathophysiology is this natriuretic peptide system. So this system is actually a good system. If we have this system activated, it will be beneficial. So when you have this heart failure, these natriuretic peptides in the form of ANP and BMP are secreted. They have a lot of positive effects on the kidneys. They induce natriuresis. Blood vessels, they cause vasodilatation, reduce the afterload. They reduce the aldosterone secretion. They reduce the sympathetic overdrive. They increase lipolysis, they increase insulin sensitivity. So there are a lot of positive effects to get by having increased ANP and BNP on board. Now, even though ANP and BNP are secreted by the heart, they are rapidly degraded by an enzyme called neprilysin. So if we can block this enzyme, neprilysin, in that case, we can increase the levels of BMP, ANP and have the positive effects. So this was the thought that went into creating a drug called sacubitril. Now there was a problem. This neprilysin is also responsible for the breakdown of angiotensin 2 and bradykinin. So therefore, this sacubitril, when it inhibits neprilysin, it's going to increase the activation of the renin-angiotensin system through increasing angiotensin levels, and it's going to cause angioedema. So in order to, and also there is a risk, already there is a risk with ACE inhibitors. ACE inhibitors itself, they can increase the levels of bradykinin. So this is a picture of angiotensin, ACE-induced angioedema. It's a rare complication, but can be life-threatening sometimes. So to overcome this problem, sacubitril was combined with valsartan. Valsartan was an angiotensin receptor blocker. So this combination was found to work quite well. Sacubitril inhibited the neprilysin, while valsartan inhibited the angiotensin 1 receptors, so it inhibited the renin-angiotensin-aldosterone system at the same time. So sacubitril valsartan was made as a combined medication, and it is the first class of what we call as angiotensin receptor neprilysin inhibitors, or ARNI for short. So it's known as ARNIs. So, and this has now been recommended in the practice guidelines. ARNI showed definite mortality benefit, mortality and morbidity benefit when it was added to as a extra added over when it was added as another medication, and it showed better effects than using enalapril alone. And another medication came into the field that's known as ivabradine. So what does ivabradine do? It reduces the heart rate by increasing the refractory period of the heart. It inhibits a current at the SA node known as the funny current. So this funny current is inhibited, and this reduces the heart rate by increasing the refractory period. So by reducing the heart rate itself, that change was found to improve the mortality and morbidity in heart failure. But this is not, ivabradine is not a substitute for beta blockers. That should be clear, because beta blockers have shown to have better mortality and morbidity benefits than ivabradine alone. So therefore, ivabradine is recommended as an add-on medication. When a patient is having a heart rate of more than 70 beats per minute in sinus rhythm and is either at the maximum doses of beta blockers or cannot tolerate beta blockers, only in these instances are we going to use ivabradine to bring down the heart rate and improve the mortality. So this is a summary of the current management strategies which we use. Now, lifestyle modification. Lifestyle is a very, very important area to concentrate on, because lifestyle, there are a lot of interventions that have proven, and a lot of trials have proven that lifestyle changes produce dramatic responses. So the lifestyle changes are poor quality diet, physical exercise, obesity, diets. So plant-based diets are better, low sodium, low potassium diets, diets rich in micronutrients and antioxidants. They have all individually been proven to be beneficial in management of heart failure. So this itself is a large topic which I cannot go into today. So heart failure and lifestyle factors play a very, very important role. So there is no point of just having pharmacological management alone if the lifestyle modification and lifestyle factors issues are not addressed. Right. Now the AHA has divided heart failure into 4 stages: stage A, stage B, stage C, and stage D. So symptomatic heart failure is going to be in stage C and stage D. So our management, when we talk about therapy, we talked about the goals, therapies that we, are pharmacological therapy, lifestyle therapies. Now, in addition to this, some patients will need things called devices. So these are known as device therapies. So the device therapies are implantable cardioverter defibrillator or ICDs. So this is recommended to prevent sudden cardiac death due to ventricular tachyarrhythmias. Patients with heart failure and low ejection fraction, they are at a higher risk of developing tachyarrhythmias. So we have an implantable ICD, an implanted defibrillator. This will give an electric shock, and thereafter it will change the rhythm back to sinus rhythm. Cardiac resynchronization therapy, or CRT. This is another interesting device which is available, especially when patients have heart failure with prolongation of the QRS interval. So in the ECG, when we have prolongation of the QRS interval, that tells us that the ventricle is contracting. That's different parts of the ventricle are contracting at different times or depolarizing at different times. So there is dyssynchrony of the left ventricle. That is the time taken for the left ventricle to contract is a long time. So while one region of the left ventricle is depolarizing or contracting, another region is still awaiting. So therefore, the function of the left ventricle is impaired. Only the left ventricle, all of the regions contract together, can we have an effective cardiac output. So this is overcome by a CRT. So they are all similar devices. They look similar. It's like a pacemaker, which is inserted subcutaneously with wires going to the heart. Another device that is becoming more and more interest is coming into this. This is something known as ventricular acid brick until a donor heart is available. But over time, many people, they have shown that LVADs can stay for prolonged periods and keep the patients in a relatively and give the patients a relatively good quality of life. But still, there is a large burden of adverse events, and it still not a practical solution. Cardiac transplantation. This is now considered the gold standard therapy for refractory end-stage heart failure. So if the heart is not functioning and if we have done everything that we can, still the patient is in refractory heart failure, then the gold standard is to change the heart. The first heart transplantation was done back in 1967 on December 3rd. It was done in South Africa, in a hospital in Cape Town. It was done by Dr. Barnard. So this was the first heart transplantation. So since then, all over the world, heart transplantation has been done. The results are very good, with patients living 20, 25, 30 years free of symptoms and having very good quality of life. So heart transplantation has improved a lot, and this is one of the best ways of managing patients, or it is the gold standard of managing heart failure, refractory heart failure at all of these changes that came up. Look at this graph. So this was a update in 2020. So look at this green color, which shows heart failure. So heart failure from 1995 up to 2015, despite all the advances that I just talked about, still heart failure seems the same. the rate per 100,000 deaths in the general population is basically the same. There does not seem to have been any drastic improvement in the heart failure outcome. Now, this is due actually to the improvement in ischemic heart disease management. So the blue line that you see is the management of ischemic heart disease. So you can see that there has been a dramatic improvement in the management of ischemic heart disease. This has resulted in patients living longer with damaged hearts. So ischemic heart disease damage, when you have a myocardial infarction, it damages the heart, and this patient is going to go on into heart failure. So although we have brought down the ischemic heart disease rate, heart failure is still a challenge. Now there's another graph on this other side, where the numbers basically the same thing, but the numbers are drastically different. Here you have 5, on the other side you have 50. Here you have 50, you have 150 per 100,000 population. But who is this population? It is the diabetic population. So in diabetic patients, heart failure, it's the same, basically looks the same graph. It's just that the numbers are very, very different. So actually the incidence of heart failure in diabetes is between 9 to 22%, that is 4 times higher than the general population. So patients with diabetes are at a very high risk of developing heart failure. So if you look at the hemoglobin HbA1c levels, you can see there's something like a U pattern. So as the HbA1c level increases even by mild levels, the heart failure keeps on increasing, the incidence of heart failure. On the other side, if the patient goes into hypoglycemia, also heart failure worsens. But the curve, the up curve, can be seen in just very small. They say even 1% increase in hemoglobin or HbA1c increases the risk of heart failure by 8 to 36%. So why is this? It's because diabetes plays an important role in the pathogenesis of heart failure. So we are usually considering about the coronary artery disease, diabetes and coronary artery disease, macrovascular complications. That is what many people consider when you think about diabetes and the heart. But diabetes has a lot of other problems as well. It causes cardiomyocyte hypertrophy. It activates the renin-angiotensin system, which itself causes myocardial damage. Calcium handling in the myocytes is affected. Autonomic dysfunction happens. So all of this together we call as diabetic cardiomyopathy. So this ischemic cardiomyopathy and diabetic cardiomyopathy together, they are going to put an increased risk of heart failure in patients with diabetes. So the pathogenesis of both of these, diabetes and heart failure, they overlap. So it's important to manage diabetes very well in heart failure. So what are our targets? So although hyperglycemia has been shown to increase the risk of heart failure, unfortunately the other way is not true. That is that tight or intense glycemic control does not really reduce the risk of heart failure in diabetic patients. Tight blood control reduces the risk of microvascular complications. But when it comes to macrovascular complications, it's not that certain. And various studies have shown that heart failure and diabetes itself is not really affected much by control of the HbA1c levels. So intensive care versus standard care, there is not much of a difference. However, most guidelines, they suggest that the ideal HbA1c threshold should be less than 7, because by achieving the threshold of less than 7, the total, we should not look just at the heart. We should look at the total person as a patient as a person, and HbA1c of less than 7 is definitely beneficial. But That does not say that the same rule should apply for everyone. So depending on the life expectancy, depending on the other complications that have already there in the patient, it is not feasible or it's not correct to go for tight, intensive blood sugar control just for heart failure alone. So hypoglycemia in these patients is an increased risk, especially in patients with renal impairment. So therefore, in these patients, it's reasonable to go for higher HbA1c targets. Now, if you look at what is the choice of what are the medications that we are going to use to treat diabetes in heart failure, the currently recommended initial pharmacotherapy is metformin. So it is shown to be effective, safe, and also well tolerated. Now people have this idea that metformin is contraindicated in heart failure. True, it was contraindicated. However, it was contraindicated prior to 2000. Many studied lactic acidosis, which was why it was contraindicated in the first place, is very low, and therefore the benefits of giving metformin outweigh the risk. And metformin has been shown to reduce the mortality and reduce hospitalization in patients with heart failure. So therefore, metformin is the first failure. If you look at the other medications, sulfonylureas, they have actually shown to increase the all-cause mortality and increase hospitalization. So therefore, sulfonylureas are not recommended to be given for heart failure patients. Insulin, the results are equivocal, but more hospitalization has been seen. The thiazolidines, so those have shown to have bad adverse effects, and therefore they are contraindicated in heart failure. GLP-1 receptor agonists, they reduce the incidence of MACE, CV, death, and all-cause mortality and things, but there is a still it is not that well proven. So GLT2 inhibitors, this is the most interesting of them all. So this has shown that there is a definite mortality benefit, morbidity benefit in using these medications. Right. So if you look at, so this again, same picture in another way. So we can see that the sodium glucose transporters, the SGLT2 inhibitors, that's empagliflozin, canagliflozin, dapagliflozin, these show improved cardiovascular. These are the ones that are showing the best cardiovascular results in both major cardiovascular events as well as heart failure hospitalization. So more interest has been seen in the recent years for these SGLT2 inhibitors. So they work by lowering the glucose levels through an insulin-independent mode by increasing the glucose excretion by the kidneys. It also has a type of a diuretic effect with a bit of an natriuretic effect. So therefore, so these are the effects that it has. Studies have shown that it improves the mortality. So it is the first class of glucose lowering agents that have demonstrated a reduced risk of heart failure hospitalization in diabetes patients. So this is the first medication to show a definite reduction in hospitalization in diabetic patients. Now, this empagliflozin has an interesting there's more research going on into this drug, because some studies have shown that even in non-diabetic patients, so this is a study which was done on non-diabetic patients, which showed that empagliflozin had, when compared to a placebo, it reduced in non-diabetic patients with heart failure. So it reduced the left ventricular volumes, it improved the left ventricular mass, it improved the exercise quality of the patients. So there is a scope for that empagliflozin or this SGL2 and receptors may turn out in the future to be heart failure medications prescribed to non-diabetic patients as well. So these are ongoing studies at the moment. So if you look at the heart failure management in diabetic patients per se, so ACE inhibitors, ARBs and ARNIs, they have all favorable effects. Spironolactone, when we start, it may modestly worsen the glycemic index in diabetic patients. So we may have to adjust the medications to improve the diabetic control in patients when we commence them on spironolactone. When you take the beta blockers, of the three beta blockers that are prescribed for heart failure, carvedilol is the one that shows the most favorable effects. Now, not only diabetes, hypertension is the other important association with or precipitating cause associated with heart failure. So management of hypertension is again an important aspect when you talk about management of heart failure. So large randomized controlled trials have shown that blood pressure of less than 120, systolic blood pressure less than 120 millimeter Hg has a significant reduction in heart failure. So therefore, the practice goal that is recommended by the AHA is to go for a blood pressure of less than 130/80 in patients with heart failure. So the medications that we are going to use is we are going to use our optimal ACE inhibitors, optimal ARBs, optimal beta blockers to bring down the blood pressure. If despite the patient is on these optimal doses of medications, in addition to a diuretic, then we can think of other medications to bring down the blood pressure. Right. So this is the story of heart failure. It commenced from the oldest records of human healing practices and grown through various changing models of physiology, sickness, and health. And today we are in an era of neurohumoral modulation, device therapies, assist therapies, and we are looking towards the future therapies. What does the future hold? So there are a number of medications that are under investigation at present. So the first one is a myosin activator. So this increases the stroke power. That's the contractility. It's like an inotropic medication, which may improve the cardiac output by improving the stroke power without having the detrimental effects of digoxin. Then the second one, it promotes diuresis, and actually it works on the NPRA receptor. That's the receptors that act with our ANP. ANP acts on this NPRA receptor. So like atrial natriuretic peptide, it's something similar, it's going to work. Then another medication that is being investigated is something called serelaxin. So this is from a family of relaxins. So relaxins are proteins that are found in the membranes of cells. So this stimulates nitric oxide production. So nitric oxide depletion and endothelial dysfunction is an important pathophysiological problem that happens with failure. So this relaxes the vessels and therefore increases cardiac output by decreasing vascular resistance. The vactans of that tolvaptan, this is a vasopressin receptor antagonist, and it can reduce the fluids in the body without uh, uh, leading to electrolyte loss. Then CT1, this is actually a cytokine. It's a type of cytokine that it's a beneficial cytokine. It is proposed to reverse cardiac remodeling. So there are a lot of exciting new medications in the pipeline, a lot of new mechanisms that are being investigated. So in the future, we will see more medications that target heart failure in using different methodologies. Gene therapy is another interesting area of research in heart failure. So this is the most promising so far. So it's a gene therapy which improves the cardiac balance in the heart. So it improves the cardiac contraction and relaxation part. So it's supposed to be, we hope that it will be more useful in patients with heart failure with preserved ejection fraction. It's another interesting place, an interesting area of research where tissue cell engineering is done. So here stem cells are engineered into cardiac patches. So these stem cells, they will basically heal the heart. So when a patient has a myocardial infarction, millions of cells are destroyed, millions of cardiac cells are destroyed. So unfortunately, cardiac cells do not have the ability to regenerate. But through this methodology, it has been shown in animal models that these cardiac cells can be programmed or can be made to regenerate. These trials are expected to start in patients in the next 2 years. So far, there has been very promising results in animal studies. Right, so that's it. So we talk about anything, it's always important to know the past, understand the present, and look towards the future.